AIDS Quilt event for 2021. We are so thankful to have you all here today. Our first speakers are Dr. Jessie Kwiek, who is a microbiology professor and researcher here at OSU, as well as Dr. Thomas Dodie Mcdow, who's a history professor and researcher here at OSU as well. All right, would you guys like to take it away?
Yeah, sure can. Let me go ahead and share our screen. Good morning, everybody. Here and here. Bucky, can you see the slides?
Perfect.
All right.
Great. Good morning, everyone, and welcome. Today we want to help us. Professor Kwiek and I want to set the stage to help us all think about what do you need to know to appreciate the AIDS quilt? What is the science and the history of HIV/AIDS that will help us put the events of today in a broader perspective, both historical and human and scientific, so for our purpose of understanding. And the work that we're doing today, and we're sharing this space because we work together. We teach a class together that focuses on the history and science of HIV. And it's a history/microbiology 3704, a cross-listed course between two departments, which there aren't many courses that cross-list between those departments. And so let us tell a little bit about ourselves. I'm Thomas Mcdow, and I'm a historian. My training is in the history of Africa, and my research has been on the history of Africa and the Indian Ocean world. I've spent a lot of time in Tanzania and Kenya, and that interest in interviewing people and working in archives, and that interest connected me to the histories of HIV in East Africa and the devastating effect of the disease there. So when I came to OSU about 10 years ago, I met Jessie Kwiek, and we had talked a lot about our shared research interests and things in common. And then in 2014, we put in a proposal to teach a class together. And this is the class that resulted from that. And so we've done it every year. We started in 2015 and done it every year since, and had a great group of students and a lot of great conversations, not only with our students at OSU, but with activists and care providers and other both infected and affected communities in Central Ohio. So let me turn it over to Jessie and let him introduce himself.
Good morning again, everybody. I'm Jessie Kwiek. I'm a microbiologist and a virologist by training. My research thinks about or addresses questions about host-virus interaction, as well as thinking about pregnant women living with HIV and how HIV still continues to affect birth outcomes, and in fact promotes low birth weight and eventually some other negative outcomes. And so we're trying to figure that out, why that's happening. I also have some connections to East Africa, and so although I grew up in the 90s while the epidemic was really bad in the United States, really my own first real exposure or immersion in the epidemic happened while I was a Peace Corps volunteer in Malawi. When I lived there at the time, approximately 1 out of every 3 pregnant women in Malawi were living with HIV. As Mcdow said, we have been working together. I'm trying to break down traditional sort of silos, and in fact, I'm trying to get our students to think about HIV from multiple perspectives, where the history and the microbiology are weaved together. And that's what we're going to do for you today, this morning as well. So with that, let's move on. So we're going to spend today about talking about HIV, but of course we'd be remiss not to mention the other ongoing viral pandemic at the moment. And there's some very interesting similarities which we'll tease out today, as well as some contrasts, right? Of course, AIDS, which is the condition caused by infection with the virus, human immunodeficiency virus type 1 or HIV, was first identified. HIV was first identified in 1983. Although, as we'll learn, we believe it crossed over into humans much earlier than that. Since 1981, we know of approximately 35 million folks who have succumbed to AIDS and AIDS-related conditions, and currently there's about 38 million people living with HIV. there are approximately at least 30, if not more, useful drugs that can be given to people living with HIV, and to date, no vaccine with useful efficacy. And of course, we can contrast that with SARS coronavirus 2, the causative agent of COVID-19, which of course was identified in 2019, where there's been almost 3 million global deaths, 134 global cases. In really interesting contrast, 3 FDA-approved vaccines here in the United States, and limited, if any, useful antivirals. And so, you know, we're living through another pandemic. So let's jump right in and talk a little bit about human immunodeficiency virus, HIV, the causative agent of AIDS. What do we know about it, and what do we know about its history? So first, at the most fundamental and basic level, if we compare things, again, using the metric system, and we look at the height of an average human, about 1.7 meters, whereas HIV is approximately 120 nanometers. And so physically, it is much smaller. It's not visible to the naked eye, only with electron microscopy. If you look at the size of the genomes, approximately 3.2 billion bases or nucleotides, so the building blocks of the genome in humans, and only 10,000 in human immunodeficiency virus, approximately. Roughly, the functional units of the genome, the nucleotides, get built into genes, which ultimately become proteins. Roughly 21,000 genes in humans, and yet only 9 in HIV. And so, as John Cohen from Science Magazine has said so eloquently, HIV is ridiculously simple, yet astonishingly complex. And it really bends the mind to think of how much pain, suffering has happened from just these 9 genes and these 10,000 bases. We actually know a lot about the HIV life cycle, and we won't go into full details on this, but through building on the work of molecular biology, some early work from Howard Temin and others studying retroviruses, which is what HIV is, that cause cancers in birds. We know a huge amount about how the virus actually co-opts a human cell and replicates. And from this amazing knowledge, again, we know that there are several unique steps that HIV has. One is reverse transcription, which is an enzyme done by an enzyme called reverse transcriptase. Another one is integration, where the HIV genome becomes inserted in and a permanent part of the host's genome. And so once it's there, to date, we really cannot remove that. And then finally, a step called processing or protease, which is done by an enzyme called protease. And really the culmination of the collection of all of this knowledge has really led to an astonishing amount of antiretroviral drugs that have been developed against HIV merely since the mid-'80s. Of course, it started off slower than everybody wanted, but it really has taken off. And again, the details here don't matter so much, just to say that there are multiple different classes of antiviral drugs. And now we're getting from multiple pill regimens to single pill regimens where they're combining the drugs together. And really, just as of this year, we now have some FDA-approved extended release injectables, right? So you could think about injectable birth control. And now we have injectable antiviral therapy, which is actually being evaluated for its utility in pre-exposure prophylaxis, or PrEP, right? So all of these molecules that you see on the screen, they block various stages of HIV replication. There's some fantastic tools out there to help you understand the HIV life cycle. And so if this is something that's of interest to you, if you see that QR code on the bottom left of the slide, if you scan that, right now it will take you to a YouTube video produced by Howard Hughes Medical Institute, which is a molecularly correct animation that is narrated that really will walk you through the HIV life cycle in a level of detail beyond the presentation today. So I'll give you a quick second to scan that if you'd like. But nevertheless, we know a lot about HIV's replication. We've done a great job at developing lots of new antiviral medicines, which are getting better and better in terms of side effects. And it's the development of these antiviral drugs that leads us to see curves like the following, right? So if we look at HIV and AIDS over from the 80s until the early 2000s, we can see that roughly in the mid-90s in the United States, AIDS was actually the leading cause of death. And so you can see how it steadily increased and increased. And then right around 1995, as soon as we started getting additional antiviral drugs, we began to have options and effective options to treat people living with HIV and to prevent them from progressing to AIDS and to prevent them from dying and allowing them to have prolonged lives, as can be seen here.
And while this story is a hopeful story in terms of drug development, it came with an immense amount of suffering and uneven suffering. So the number of people who died early and the groups most affected by AIDS in its early years tended to be people with less political power or representation and were marginalized, including men of sex with men and other minority groups. So, and one of the responses to that, of this loss and the lack of acknowledgement on the political front, was the creation of the Names Project and the AIDS Quilt in 1987. And so here's a scene from the first sharing of the AIDS Quilt in 1987. You can see the White House in the background, but a chance to remember those who had died from the time from the first cases that were acknowledged in 1981 through the 1990s, when the drugs began to be available, although people have continued to die from AIDS. So we want to think about that. We want to remember and acknowledge the suffering and to think about what has happened in the United States and the populations that have been affected. Because when we think about this history of HIV in the US, there's so many stories that can come from that, so many ways that HIV and AIDS can help us understand the past and understand the present that we live in today. And so the things that come out from this, the way that the stigmatization of groups that were affected early, the way that affected the care that was available, and that things were not rolled out broadly because the groups that were marginalized. But this marginalization had another side to that, was through action and protest, a new degree of visibility, especially for gay men and others in society. So a recognition of the place of gay people in society and how many people were there. The other part of the story, of course, is discrimination and the suffering that came from that. The presidents and people think about Reagan, but Bush and Clinton were also slow to act or didn't take the steps they could have. We can think of a culture war that was going on at the same time about what the role of government was and where culture, what should be the proper culture that people practiced. The story is also set up who made demands and changed the way we got access to drugs, that changed the way that drugs were tested and made available to the public, set up to make treatments available. Again, we can see the echoes today. We've talked a bit about the science, and that tends to be a very positive story. We sometimes worry that the positive stories of science leave out the people involved and the suffering that took to get there. And so memorialization is vital to this aspect. So in 1987, just 4 years or 6 years after the first cases of AIDS were recognized, people began to commemorate World AIDS Day, celebrated on December 1st, to acknowledge those who had the disease and who died from the disease. And that was also when the AIDS quilt made its debut. This is the story. This frames an American story and thinking about things in an American way. But one of the important points to leave with today is to understand that AIDS and HIV are and have always been a global phenomenon that affect people around the world. And so when we think about the immense suffering in the United States and the loss of lives, the individuals, people who lost brothers and uncles and husbands and friends and partners and sisters and nieces, right? When we think about those losses, we can imagine them in an American context, but we also need to think about the disproportionate effect of people in the world. So when we try to line up AIDS-associated deaths in the world, the scales that we have to use between North America and Sub-Saharan Africa are completely different. So if you look, this is from 1990 to 2016. You can see the curves of the deaths, right? And so the blue curve follows what we saw in the earlier slide about the leading cause of death, and we see the tremendous fall off in associated deaths or HIV-associated deaths after introduction of antiretrovirals. But if you look at the green curve, this to me points to one of the great disparities in the world, in the sense that even as drugs became available in the United States and the AIDS-associated deaths fell rapidly in North America, they continued to sub-Saharan Africa. And the numbers you can see, the numbers in the green on the side are so much higher, of 1.6 million people per year dying in sub-Saharan Africa in the 2000s, even though drugs were available in some parts of the world. So AIDS, like many epidemics, points to the inequalities in the world, points to the fault lines, and points to vulnerability and the way that the global world has been put together. It took more than 10 years to get antiretroviral drugs to most of sub-Saharan Africa, and you can see that even today, the prevalence of HIV in the world, that sub-Saharan Africa particularly is bears a much greater burden of disease and greater prevalence than any other part of the world. And so, trying to keep in mind the balance between the United States and the rest of the world, and to understand that sub-Saharan Africa is that has the greatest burden. So in 2018, 68% of the people in the world alive with HIV lived in Africa. And an important thing to remember about the African epidemic, I mean, a global epidemic, but the African pieces of it are that more women than men are affected, right? And so in the United States and North America, it tends to be more men than women. And that the primary transmission is between penile vaginal sex. And so again, that's a different profile than you would think of this disease if you're coming from a strictly United States perspective. So we want to keep that global perspective in mind. And part of this is to think about that HIV can only live in humans, and so it depends on the human population and the social factors and other things that structure the lives of people in those situations. And so that HIV doesn't exist well outside the human body, we can be grateful for. But the challenge of this is really, until very recently, humans couldn't live with HIV. And so when we think about the possibility of living with HIV and the possibility for a cure, there's a few very small number of hopeful cases, hopeful stories, but a lot more to think about. Jesse, you want to talk about the two cures?
Yeah, sure. And so through sort of the marvels or some astute thinking by some clinicians, as well as some fundamental observations from molecular biologists, demographers, population biologists, people who study HIV around the world, two people have actually been cured of HIV-1. On the left, Timothy Ray Brown, formerly known as the Berlin patient, and on the right, Adam Castillejo, known as the London patient. And so there are two examples. However, in both cases, the modality, the treatment used in order to cure these two folks of their HIV is not something that's widely accessible. And in fact, the intervention itself has a high mortality rate, which remains ethically challenging to prescribe, given that HIV can be managed and people living with HIV can live long lives without the cure. Nevertheless, these two cures have provided inspiration as well as given rise to a whole bunch of innovations, a next generation of possible cures that people are investigating that have lower levels of potential mortality and yet might be able to permanently eradicate the virus from people living with HIV.
But that's those rare cases. We still need to keep in mind what people have said from the beginning: AIDS has no cure. And what are the implications of that? What does it mean to study or think about a disease that can't be cured? Thank goodness, with antiretroviral therapy, it can be controlled and virally suppressed to the degree that people can't even transmit the virus anymore. But if we want to think about and understand the disease in its historical context, we need to think about not only the early suffering before any of these medical interventions came about, but to go back further and to think, well, where did this virus come from? How did it infect humans? How can science and history help us understand the deep history of HIV before it even surfaced in 1981?
And for that, we turn to molecular paleovirology, if you will, this idea of extracting virus from archived tissue samples from around the world, using the modern approaches to molecular biology, sequencing viral genomes, and then using what we know about evolutionary history and evolutionary biology to recreate and to understand exactly where the virus came from. And so through the work of scientists like Beatrice Hahn and others who went out and sampled fecal matter from all kinds of non-human primates all across sub-Saharan Africa, we know now that HIV is most closely related to a sister virus called simian immunodeficiency virus, abbreviated here, SIV. And again, as you start to sample non-human primates, you see that most non-human primates have SIV and they have their own unique form. So if we start to build a family tree, a molecular family tree of this, and start to sequence it, we can see that HIV-1, group M, which is the cause of the modern epidemic, is most closely related to SIV that is currently in chimpanzees of the subspecies Pan-troglodyte troglodyte, as shown here. But again, through molecular biology, we've been able to put this all together and really figure out a fascinating story of where did this virus come from? Where did the spillover possibly happen? And that allows us to think about future spillover events and future global pandemics. And again, if this story seems really interesting to you, there are some fantastic resources that you can use to learn more about this. There's a book by Jacques Pepin, shown here at the right, called The Origin of AIDS. He just came out with a new version, an updated version of it here in 2021. This is a book that we teach within our class, and it really gives a fantastic perspective, although with some nuances about this spillover. If books aren't your thing and you prefer to listen to a podcast, there's a Radio Lab podcast out of New York City, hosted by Jad Abumrad, and he has a whole episode called Patient Zero, where they interview Carl Zimmer and some other fantastic science writers and storytellers that elaborate just where HIV came from and how we know that. As some of our students have said in a previous class, we also know that SIVs and HIVs can recombine. And so as a student explained it, we know that the infection in the chimpanzee came from two different SIVs. It mixed together and it ultimately was transmitted to humans. For those of you that are really into the molecular side of things, this is how we know where HIV came from. And so this is what we call an unrooted phylogenetic tree here. And so at the tips here, and the ends of all of these lines, these are actual sequences, genomic sequences from all the different SIVs or all the different HIVs that are in the world. And the one thing that you need to know about this diagram is that the longer the lines are, the more distantly related things are. So the closer the lines, the closer the relationship between the different viral sequences that we see here. And so this here, this cluster, this little group of branches is the cause of the modern epidemic, HIV-1 group M. And if we follow that line down, what we can see that the closest branch that we come to is this SIV from chimpanzees, from Pan-troglodyte troglodyte. And so it is this small distance right here from that all the way over to here that lets us know that SIV from chimpanzees is the most closely related virus to HIV, and thus, the causative agent, the predecessor, the most recent common ancestor, if you will, of HIV. But that's just one part of the story. That's the molecular part, and these lines don't do a good job of telling us where this happened, how this happened, or in whom this happened.
So if we want to think about where, Beatrice Hahn's work also helped narrow down the place of the particular chimpanzees who had a particular kind of simian immunodeficiency virus that was most likely led to the HIV-1M infection, and that's in the space where this is, which is in the southeast corner of Cameroon in the Sangha River Valley. And so a key aspect of this is to note that this is in equatorial Africa. It's in riverine equatorial Africa, where rivers made mobility over long distances possible even before there were steamships or other things in the region. And so we can think about the mobility of people, although it turns out chimpanzees don't cross rivers. And so that's one of the ways we were able to figure out where this happened by looking at that. But in putting together those molecular sequences, one places the molecular sequences were found were actually in Kinshasa, which we can see as number 3 here on the map. So understanding the story and putting together the how, it's thought that a human who had hunted or had received the carcass of a chimpanzee and was butchering it, so the chimpanzee, there's chimpanzee blood, the hunter likely cut him or herself, and then thus exposed their own blood to chimpanzee blood infected with SIV, and this created the human virus of HIV. But let's go back. Sorry, just to go back one more. So that happened in the southeast corner of Cameroon. Most likely, these riverine networks, people move around because it was that. And number 3, the capital of the Democratic Republic of Congo, Kinshasa, which is the colonial city of Leopoldville, is where the first samples were found. Where the paleovirologists were able to use samples that had been stored, one from 1959 and one from 1960, to recover sequences of HIV, which allowed them to do the dating, the molecular dating that help us understand that. But again, this seems like a very unlikely story. There's a lot of other pieces that need to be in place for a single crossover event, a spillover from chimpanzees to humans. What other factors, what are things of the moment that would have amplified this virus and made this happen? And for that, we need to think about the story of European colonialism in equatorial Africa. This period is the same period of overlapping period with the story of the Heart of Darkness, Joseph Conrad's famous novella that is one of the things that contributed to him winning the Nobel Prize in Literature. That helps tell the story. We can think of a set of technologies that came into place. The steamship, the paddle steamers that were used on the river, that one of the things that Captain Kurtz had sailed up the Congo in his search for ivory were the steamers that had been introduced onto the river from the 1880s that were to help move goods around and for the exploitation of both the forest products of the Congo, including timber, ivory, and a terrible, brutal regime of extracting rubber from the Congo River Basin to feed the rubbers at Akron, Ohio, and other places. At the same time, colonial medicine also played a role in the sense that intrusive procedures like the lumbar puncture from the studies shown below, but also attempts to treat people for disease, well-meaning attempts to offer vaccinations or other things, often reused needles or didn't sterilize needles all the way between uses. And so this medical amplification of the virus, because it passes very easily from blood to blood or needles and leads to much greater infection. These are some of the things that helped multiply the number of people with the virus and amplify its viability. And so these pictures are from 1910 and from 1933. It's in this colonial period. When we line this up with both when this spillover likely happened, which the molecular dating suggests between 1883 and 1923, and then look at the growth of urban centers in equatorial Africa, we see that the spillover, when combined with this mobility and colonial medical practices and the growth of populations where the colonial character of cities where men were brought to cities for work, there were few women, so the ratios of men to women were skewed in the favor of men. There was transactional sex and other things that occurred there, and so these also amplified and spread HIV. And so thinking about the story, we have the spillover event, a hunter someone butchering a chimpanzee, but then thinking about the historical factors that would spread this to people. Part of it is just being in a city, and we think about the city of Leopoldville and Kinshasa here on the Malebo Pool, a natural stopping point on the river where people have gathered. Kinshasa is the capital of the Democratic Republic of Congo, and Brazzaville across the river is the capital of the Republic of Congo. These are two of the fastest growing cities in Equatorial Africa. And as I said before, places where samples, one taken in 1959 and one taken in 1960, contained HIV. So we know that there were people with HIV in Kinshasa or in Leopoldville in 1959 and 1960, during the time it was the Belgian, not in an independent country. But we also want human factors, the very factors that brought this disease together and brought it to this place and made it possible. Also is one that sustained a vibrant nightlife of urbanized young people coming together. The music that came out of this period was influenced in some part by Cuban rumba, and it's called Congolese rumba, but has taken over the. If you've ever ridden public transportation in Africa, you're going to have heard some of this music. The practitioners, got their start in the 40s and the 50s and the 60s in the Congo, playing in bars and scenes like this. So young people out and about, having, with an idea of a bright future. This picture is from 1958 in Leopoldville or Kinshasa. So, how does this disease that is only in one part of the world become a global disease? And if we think about HIV coming of age under colonialism, decolonization in sub-Saharan Africa led to the global spread of HIV. So I'll tell you a little story about how this happened. And part of it is about the Prince of the Congo, which occurred in June of 1960. Here we see the Belgian king who came to hand over the country to the Prime Minister-elect Patrice Lumumba, the President-elect Joseph Kasavubu. And in the moment of the speech, when the king, made remarks, but they were withering remarks, not kind to Congolese people. Patrice Lumumba stood up and made a much more fiery speech about Congolese independence and the route that he hoped to make for the country. But of course, independent in 1960s did so in the midst of the Cold War. So the West became immediately suspicious of Lumumba and his role. Would he turn over the vast mineral wealth of the Congo to the Soviet Union and the Eastern Bloc? Right, because it was in the Congo in the 1940s that they had mined the uranium that fed the Manhattan Project and was part of the atom bomb that was dropped on Japan. So controlling uranium and access to these rare elements, but also the other more common metals that were mined in the Congo were vital. So the economic control and the military control of the Congo was important. This led to a crisis because within a month of Lumumba's government taking over, the richest province seceded and said they would be on their own to pull their minerals as they wished. On the copper belt, that was in a month after independence. And so this, in the midst of this Cold War, led to a Congo crisis where Patrice Lumumba, less than a year after becoming president, was handed over to his enemies with the complicity of the CIA and was assassinated. When the Secretary General of the UN tried to get involved and make sense of this, UN peacekeeping forces were sent to the Congo to try to sort things out. But he died in a mysterious plane crash just 9 months after Lumumba had been assassinated. So the Congo, this kind of geopolitical crisis in the Congo had other real effects in the sense that the Belgians had not prepared the Congolese for independence. There were no doctors, no Congolese doctors at the time of independence. The medical system and the education system depended on European expatriates and missionaries, nuns, and other to run the medical systems and much of the educational infrastructure. But many of those people, the expatriates, fled to this crisis. So by 1965, another coup had brought Mobutu to power, who tried to stabilize the country as a Cold War dictator, as a staunch ally of the United States. But the ranks of the civil service were depleted. And so they tried to recruit people from elsewhere to come in and make up for the lack of the Congolese professionals that had not in place because of Belgian colonialism. And the place they went to do that was in Haiti, which was a French-speaking country in the Western Hemisphere, but they had their own Cold War dictator, Francois Duvalier, known as Papa Doc. And of course, he had studied public health at an institution nearby in the United States, and then returned home to become a brutal dictator. But it meant that under his rule, the educated elite of Haiti were eager to get out and find employment elsewhere. Many of them went to the Congo. And so by 1967, there were 4,500 Haitians working in the Congo. And at least one of these people contracted HIV and traveled back to Haiti with it. And this is one of the ways that the virus that causes AIDS jumped the Atlantic Ocean. Again, it's a story that has to do with the decolonization of Africa and the Cold War politics that made this possible. That this virus, which had begun in this southeast corner of Cameroon, moved through riverine networks to the burgeoning cities of Kinshasa and Brazzaville. Then, in the tumult of decolonization and the Cold War, crossed the Atlantic and enter the Western Hemisphere.
And it turns out, if you turn back to molecular biology again, the molecular biology perfectly aligns with this historically plausible story about how HIV went from, again, Central Africa, Kinshasa, over to Haiti, and then to the United States. And so again, some scientists at the University of Arizona and elsewhere went on and they dug through archives of blood that had been banked from Haitians living with HIV or Haitians who had died prior to the identification of HIV, and they started sequencing. And from those sequences of HIV from Haiti, from New Jersey, from New York, from California, they were able to go back and build yet another phylogenetic tree, this time colored, with the colors meaning, again, the different geolocations. And again, so just to orient you, these samples were removed from freezers, and so they know approximately when the samples were taken. Each tip here represents an actual sequence of the virus, and then the collection and the way the shape of this curve tells us how these things are related. And what we know from this sequencing is that the first sequences went from the Congo to Haiti, as shown here, because that's the oldest sequence that we have. It then looks like this, the virus moved to New York, spread to Georgia and to California. And the molecular data that we have at this time paints this story and outlines it nicely again through this phylogenetic tree. But of course, as this was happening, people were starting to, there was, people wanted to know who had done this, who spread this virus. And so if you look right in the middle of this tree, you see patient 0, right? So this is a flight attendant, Gaetan Dugas, who was essentially vilified and made to be demonized by the media as this hypersexual rapid spreader that just wanted to get HIV, wanted to spread it everywhere. And so through some misreading of some documents, it turns out actually he was not patient 0 at all. He was known originally as patient O for other than California and New York. However, through a transcribing mistake, he became identified as patient 0, and these stories were told. Again, through the collaboration between historical stories and records and molecular phylogeny, as we see here, we now know that in fact patient 0 was not even close to patient 0. If we sequence his virus, it's smack in the middle of all these other viruses that already existed and already were around. And so here again, we see a fine example of molecular tools really either collaborating in the case of collaborating with or affirming stories in the case of how HIV went from Central Africa to the United States, as well as contradicting common stories that patient zero, Gaetan Dugas, was the source of the virus, the contemporary epidemic in the United States, which is clearly not the case.
And attempts to vilify queer people in the early years of HIV also hides a story of heroic actions and things that we need to keep in mind. And other people with HIV who were disowned by their families, unwilling to sit with them by their bedsides, their partners and friends took over the role of caring. We see the much greater visibility for the gay men and lesbians in taking care of each other and of giving greater visibility to the patients suffering, right? And this is the time when people put together panels on the quilt and to remember those that had died. So here's a set of panels that were created for people who had died in the late 1980s, a chance to memorialize and to remember these individuals. Because when we think about public health and we pull back and we think about numbers, and we'll throw some numbers, we have to remember that every single one of those numbers was a person, someone who was connected to friends and to family. And I think that one of the powerful things about the quilt that it does is it grounds us in that. It reminds us about the human relations. It reminds us of the people who loved those who have died and who remember them. And so when we start crunching the numbers and thinking about epidemics, right, we in our class and the way that we approach this, we don't want to lose sight of people and their experiences, because it's not only the individual experiences as the move together, but also the collective experience of working together to fight against this. And so we see the prominence of activism, right, and the rise of the slogan, silence equals death. Queer people sit by and do nothing, we will suffer and we will die. And so the seizing of the narrative, and also taking the fight to the U.S. government, to the Catholic Church, to other people who were dragging their feet on AIDS. So we see, drawing on the tradition of Stonewall and of queer activism and visibility that has started from the 1960s and even from the 1950s in the United States, but also, in protest movements that drew from the same practices of this movement and the movements of that era, to take the fight to the NIH, right, and to call them out for early drugs, like poison from AZT, which was one of the first drugs that was made available, but was one as a monotherapy, was quickly defeated by the virus, but also had in the early doses was killing people. And so these protesters calling out both the drugs that were available and the profits that the drug companies were making. The first rounds of AZT were cost more than $10,000 a year per patient, which was just unattainable for most people with the disease. And so here we've thought about the science and we've thought about the people, but one of the things that shapes this is the politics of the moment, right? And so I think Jesse can tell us about some of the unusual parallels from the past and the time that we've recently lived through.
That's right. And you have to forgive me. I just realized I didn't share sound, so I'm going to stop sharing for one quick second. I'm going to hit share again, share sound. Boom, boom, boom. That's right. And so the politics, right, and the stigma that comes from our political leaders and how they frame these epidemics, how they speak about them, and how they share them. And so we've got two short video clips here that'll just remind you what happened in the 80s, as well as what is happening with the modern epidemic. This first video is going to look at Larry Speaks, spokesperson for the Reagan administration, and how he framed the epidemic.
President have any reaction to the announcement of the Center for Disease Control in Atlanta that AIDS is now an epidemic in over 600 cases? And, over a third of them have died. It's known as gay plague. No, it is. I mean, it's a pretty serious thing. That 1 in every 3 people that get this have died, and I wonder if the president is aware of it.
I don't have it. Are you? Do you?
You don't have it. Well, I'm relieved to hear that, Larry.
Do you?
No,
You didn't answer my question.
Well, I just wondered,
how do you know?
Does the president, in other words, the White House looks on this as a great joke.
No, I don't know anything about it, Lester.
Does anybody in the White House know about this epidemic, Larry?
I don't think so. I don't think there's
Nobody
been
knows.
there's been no personal experience here, Lester.
No, I mean, I thought you were keeping...
I checked thoroughly with Dr. Rugi this morning, and he's had no no patients suffered from AIDS or whatever it is.
The president doesn't have gay plague. Is that what you're saying, or what?
No, didn't say that.
Didn't say that.
I thought I heard you on the State Department over there. Why don't you stay over there?
Because I love you, Larry.
Oh, I see. Well, let's don't put it in those terms, Lester.
Oh, I retract that.
I hope so.
So you can hear in the language, the tone, everything about it, just how the administration reacted and how they generated stigma. And lest we think this is just a product of yesteryear, as we think about the current pandemic, we have similar things that are happening even today.
Why do you keep calling this the Chinese virus? There are reports of dozens of incidents of bias against Chinese Americans in this country. Your own AIDS, Secretary Azar, says he does not use this term. He says ethnicity does not cause the virus. Why do you keep using this? A lot of people say it's racist.
It's not racist at all, no, not at all. It comes from China. That's why. It comes from China. I want to be accurate. Yeah, please, John, please.
Behind you. Are you
I have great love for all of the people from our country, but as you know, China tried to say at one point, maybe they stopped now, that it was caused by American soldiers. That can't happen. It's not going to happen, not as long as I'm president. It comes from China.
So we can't disentangle the medical condition, the molecular biology from the politics in the way that has shaped our response and our attitudes towards people living with these viruses and our response with them. And yet, despite all of the progress that we've talked about, HIV still has a global reach. Worldwide, we see that there are growing rates in China and Eastern Europe. There's disproportionately high rates in Africa, again, through 68% of all people living with HIV are in sub-Saharan Africa. And despite education and a lot of great effort from folks in Central Ohio and around, we still have steady rates of new HIV infections in Ohio as well. Looking at the global burden and the unevenness of it again, now broken down by geographic region, some recent data from 2019, again, looking at number of new infections, we still see that Eastern and Sub-Saharan Africa are disproportionately carrying, or that's where disproportionately the number of new infections are, as well as the number of AIDS-related deaths. Bringing it back home here in Ohio, if we look at the Ohio HIV epidemic, with some statistics provided by the Ohio Department of Health, again, if we look at the gray line, the number of new HIV diagnoses, so the axis over here on the right, we can see it went up and it peaked in the mid-1990s, early 1990s. There were starting to be some declines, then some increases, and now we're at a plateau. Again, if we look at the number of people living with HIV, that has steadily increased, which is a product of the number of new HIV diagnoses, but of course it's also a product of the evolution of our ability to generate new therapies that allows people living with HIV to live longer and more productive lives. And yet, through all of this and through all of these stats, as we've said time and time again, HIV remains a human epidemic. And even with treatment available, and through the words of Tony Fauci in 2016, We have the therapies, no more excuses. We have the tools to end the HIV/AIDS pandemic. And here in this case, showing pre-exposure prophylaxis, which is a pill that can be taken by somebody who is not living with HIV in order to prevent them from acquiring HIV.
So we have the tools, but yet the risk of acquiring HIV is skews greatly against people who have marginalized places in society or that social structures don't support as they should. So the way that people think about, and that UNAIDS tries to frame things, is to think about key populations, people who are at most at risk and who need the most outreach and access to care. And so if you think about 62% of all new HIV infections in 2019 were among these key populations, which includes sex workers, people who inject drugs, men who have sex with men, transgender people, and incarcerated people. The UNAIDS figured out the risk multiplier, and if you look at these numbers, the sex workers are 30 times more likely to acquire HIV than a normal person. And that, again, the numbers for people who inject drugs are men who have sex with men, and transgender people. Incarcerated people, they don't even have good numbers on that. But these are key populations that are most affected. And these are at a global level. If you look at what the risk in the United States today, you'll see these numbers skew very unfavorably to people of color, especially to trans women of color and the Latinx population. So these are the risk. These are products of political choices. These are products of policies. These are products of social stigma. They are things that we can do something about. They're places where we can take action and change the way society does things. If we look at the upcoming goals that UNAIDS has for the world, they want, the old scheme was thinking about 90-90-90, that 90% of people would know their HIV status, that 90% of those people would be on antiretrovirals, and that 90% of those on antiretrovirals would be virally suppressed. Those numbers have been updated to think about the less than 10s, the 95, and the 90. So these goals on the left, that less than 10% of the countries would have punitive laws and policies for people who have HIV. There's been a huge push for decriminalization of HIV, and it's happening in Ohio and other places. That fewer than 10 people experience stigma and discrimination or experience gender inequality and violence. So how to reduce those things? Again, these are social and political questions that we are connected to and can be part of. For the 95%, getting 95% of people to use combination prevention. Again, from the 90-90-90, the next three, that people living with HIV, 95% know their status. Of those who know their status, that 95% of those initiate treatment, and that 95% of those are virally suppressed. Again, we have the drugs, we can do this. We need to make them available. We need to reach communities that have not been reached. We need to rethink approaches that allow these things to continue. We want to make sure that UNAIDS wants to make sure that 95% of the services that eliminate vertical transmission, meaning from mother to child at birth or through breast milk, that those things are covered. And also that women have access to HIV and sexual reproductive health services. As we pointed out, in Sub-Saharan Africa, women have a greater number of HIV cases, but women are at risk elsewhere too. And so making sure that women have access to these services are vital. And that the 90% is that 90% of people living with HIV and those at risk have connections to specific integrated services and the services that are people-centered. So the whole idea of the UNAIDS goals for 2025 is people-centered and being centered on communities at risk. And so when we think about the communities that we're part of, when we think about the global that we're part of and the interconnections that this story of HIV puts together, that takes us from equatorial Africa in the days of colonialism to the United States and Columbus, Ohio in 2021, we have to think about what we can do, because we all now know something of the science. We know something of the history. We can commemorate the past. That's what the AIDS quilt has done. But what will it take for us to stop adding panels to the AIDS quilt? Here's a picture from when the quilt visited in 2019. The group that's putting on this conference today brought it here. We see the role that they're playing in helping us commemorate these things, but there's roles for all of us to play in ending HIV, ending the stigma around HIV and the discrimination that affects both people with the disease, but populations who are likely to get the disease. So we think that by combining science and history and activism and the potential of students like the ones who are organizing this conference, that we can reduce the number of quilts, the number of panels in the HIV quilt, and look at that, and hopefully it becomes a historic relic where we can remember the lives lost and the human efforts that were made to save future lives. Thank you so much for listening to our talk. I think we have about 5 minutes. If you have questions, we can take those.
That was absolutely wonderful. You're right, we have about 5 minutes left here today. We have one question from our student org that says, can they talk about the possible HIV vaccines out there? I've heard a lot about criticism on TikTok and why the COVID vaccine has been developed so quickly, but we still don't have an HIV vaccine after 40 years. Can they explain why this hasn't happened yet?
So I'll take that question. It certainly isn't for lack of trying. There have been billions of dollars spent on new vaccine platforms tested, many of them at the AIDS Clinical Trials Unit here in Ohio and across the US and across the globe. Simply put, we're trying and it just hasn't happened yet. One possible reason for that is that HIV has been adapting to humans for more than 100 years. And so it's basically the virus has a lot more diversity, if you will. It has a lot more changes in its sequence. And so it's a lot harder to make a vaccine that's possible to eradicate or attack HIV that is all over the world. Whereas perhaps with the coronavirus vaccines, we caught this quickly after it transitioned or spilled over into humans. We used some new technologies, which are now these messenger RNA vaccine technologies, which are being tried for HIV as we speak. And perhaps it was all of the advances of modern science left us in a position so that as soon as this new virus spilled over, we had some new ideas to try. And we had some new platforms to try while the virus was still relatively young in terms of how long it had been in the US. So we don't know exactly why it hasn't happened, but certainly the COVID vaccine trials have benefited from the infrastructure set up by the HIV AIDS vaccine trials. And now we're trying to wait and see if the reciprocal is true, that perhaps HIV vaccine technology can also benefit from what we've learned from some of the COVID vaccines as well.
Wonderful. Are there any other questions? We have one more from our student org that says, okay, what about PrEP? I should probably know more about it, but I honestly don't. Can you give a quick 2-minute version of what PrEP is?
Sure. PrEP is taking antiviral medications by people who are not currently living with HIV, but might be at increased risk of acquiring HIV. So it is some, in the weeds, it's reverse transcriptase inhibitors, but it's a combination of pills that can be taken. There are all kinds of resources. If you Google Ohio PrEP, there are ways that it can be made affordable. There are ways that you can access it through your healthcare provider, through Equitas Health, through other fantastic resources around town. And so, it works. It's greater than 90% effective at reducing HIV acquisition. And certainly when part of a combination of multiple different strategies to prevent HIV transmission, it certainly is incredibly helpful. So I guess I would say, Google it, where you can find PrEP. If you can't afford it, again, there are resources. There's a program called the PAPI program, which can help people to find the financial resources if you can't afford it as well. So,
and just to tag on that, the one thing we didn't say in the presentation, but I hope will come up again at some point today, U equals U. It means that if you are virally suppressed, it means you can't transmit the virus. Undetectable equals untransmissible. And so people who are on PrEP, people on PrEP does the same drugs, but people who are who are taking HIV drugs and are virally suppressed cannot spread the disease. So again, this is why we need to rethink criminalization to catch up with the science. There are lots of things to do, but it's possible to live with HIV and to be completely virally suppressed. So that's the U=U campaign, which if you need to know about PrEP and you need to know about U=U, those are the tools that will help you navigate the HIV world today.
Perfect. Thank you guys so much. That was an amazing presentation. I certainly learned a lot as well. You can stay along and answer any questions in the chat if we get any, or you can take off if you want. Thank you guys again.